Hello everyone, my name is Hisham. I'm one of the tutors at the Matcha Guy, and in today's session, we're going to discuss some of the high yield topics in biostatistics, which is the differences between study designs. So as you know, biostatistics is very challenging for all the USMLE steps, and well, in this session, I'm going to make it more easy, and we're going to do many questions to cover this topic. So let me share the screen with you first, and then we'll go over uh, everything. Okay. Yeah, so as you see here, we have study designs. First of all, as you see, we have different types of study designs. We have the observational studies and we have the experimental studies. So first of all, regarding the observational studies, we have cohort study, cross-sectional, case control studies. We have case series and case report. And finally, we have systematic reviews and meta-analysis. But in experimental studies, we have only the clinical trials, which could be randomized vs non-randomized clinical trials. Yeah, so let's take it one by one. Let's start with observational studies first in the next few slides. So case reports is only one case. Like one interesting case is reported. For example, a typical presentation of a patient with giant cell arthritis. But case series is similar to case report, but here I'm including, many people, like maybe 30 patients, for example. So case series, and the case report, we're talking about only one patient or one group of patients. Cross-sectional study, it's the same. It's one group. Okay, so I have one group and I'm doing a survey there. So it's not two groups. So what is the thing about a case cross-sectional study is that it's a snapshot in the present time, and it only shows association. Okay, and there is a very common statistical, rule called that association does not imply causation. So if I mentioned in the same question, A is associated with P, it doesn't mean that A causes B. Okay, so make sure there's difference in the words. Okay. Yeah, one of the common example or the classic example here is the shoe size and IQ. Like, there is an association. If you have larger shoe size, it's more likely that you have a high IQ. And it makes sense, when you get more older, the IQ, increases time. Well, but you don't know which one caused the other. Like, does the high shoe size, cause high IQ or the opposite? So you know, uh, it only, imply association. Well, it's only associated, but it doesn't have anything to do with causation. And there are many, many examples here. For example, hypertension. These people found that maybe they have mutated sodium channel, for example. So just we have, some interesting association between hypertension and mutated sodium channel, but you don't know if mutated sodium channel cause hypertension or not. That's why you have to do different studies, and we have to have two groups, one control group and the main group, and to compare between them. Okay, here in case control studies and cohort studies, these two studies it showed causation. Okay, and also we have two groups. Okay, so from what we described before in the last slides, it's two groups, but here it's only one group, but here we have two groups. Case control and cohort study. So the difference is in case control studies, we have a disease, it's established disease, and we look in the past for any risk factor. For example, a patient with diabetes, and or maybe a group of patients with diabetes, and we look in the past for any risk factors. For example, let's say obesity or high BMI. Okay, so we look retrospectively. Cohort study is the opposite. We have patient with risk factor, let's say that smoking, and we look in the future for any maybe disease. Maybe we follow up with this patient in 5-10 years, and we look for any disease. Yeah, smoking and lung cancer, for example. So that's the main difference. And yeah, this show causation because now you can know if obesity can cause diabetes, or maybe if smoking can cause lung cancer in the future or not, because we have two groups and we can compare between them. So yeah, let's go over a question, to make it more easier and highlight some, some defects. Like, for example, here in the first question, we have, 100 patients who were recently, diagnosed with lung cancer, and 100 individuals with the disease. So first of all, we have two groups here. Okay, so two groups could be case control study or cohort study. Well, we can, cross out cross-sectional study. So randomized control trial is also two groups. But, we already rolled out, cross-sectional study because it's two groups. Here we have, patient with, the disease, which is lung cancer. Okay. And we are investigating any prior history of tobacco use. So we look in the past for any risk factor. All right, so this one is case control study because you're looking retrospectively. The next question, we have also two groups. So two groups, we roll out cross-sectional studies. And we have case control, prospective cohort, retrospective cohort. So as you see here, we have the risk factor itself, smoking, and we look for a disease in the future, which is coronary artery disease development. So follow up over 10 years. So smoking, follow up 10 years, and then we look for the disease, which is coronary artery disease. Okay, so this one is cohort study, but we have two types of cohort study, as you see here, prospective and retrospective cohort. So since we're looking in the future, it's a prospective cohort study. This question, a little bit similar to the one we just did right now, but let's see what's the difference. So we have a researcher reviews the medical records. So medical records here is the buzzword for the answer. Okay, like once you see a medical record, usually it points to retrospective cohort study. So, but anyway, we have here 400 patients. This 100 patient, from 215 to identify those with BMI over 30 and a control group with BMI under 25. So again, we have two groups. So we crossed out cross-sectional study. Okay. Yeah, so here, you started with the BMI and you tracked, these people in the past. Okay. So we don't follow up in the future. We track in the past to determine diabetes. Okay. So here's, the present time, and here's, the past time. So in the past, I started with BMI, and I follow up in the past, like we have medical record, you track medical record in the past. So this one is retrospective cohort study. So the difference between retrospective cohort and case control is, both of them we look in the past retrospectively, but in case control, you start with a disease like diabetes, and you look for BMI. So this one is case control study. But if you start with BMI and looking for diabetes in the past, well, this one is retrospective cohort study. Okay. All right. Yeah, and then the other study here, as you see, this one looks more distinct. So, for example, we're doing this study over cities, like 50 different metropolitan area. So once I mentioned cities, states, comparing neighborhoods. So basically, it's like city level, not individual level. The answer, usually is ecological study. Okay, so this is different from the other studies we did before. For example, here cohort study we do individuals like 400 patients, but here we only care about the whole city, the whole state, the whole country. So that's called ecological study. Also, one important thing here regarding the ecological study, it's applicable to, cities, for example, not individuals. For example, if I say that, well, we found that exposure of substance A increased risk of developing, coronary artery disease in this city by 50%. Okay, so this is applicable to the city. So if an individual from this city present to the office and say that what is my risk of developing coronary artery disease, if you said 50%, that's wrong because this percentage is applicable to, to the people, like many people. So it's not applicable to individuals. So here's an important note I want to highlight. Okay. And also, they may ask you in another way, like here we have a case control study, okay, and it assesses the link between high blood pressure and developing dementia in elderly patients. Okay, so first of all, there's case control study. So in case control study, you start with a disease. What is a disease is? Is it high blood pressure or dementia? Well, dementia here, makes sense that dementia is the disease. So dementia, and we look, retrospectively for risk factor, which is blood pressure. Okay, so what is the characteristic of the main group? So the main group here is, which is group A. So let's say that we have two groups, group A, which is the main group, group B is the control group. So group A, it has people with dementia, which is the disease. And also we're looking for other characteristics, as you see here, the patient should be more than 70 years. They have hypertension, they have diabetes, they have obesity. So what characteristics should be present in group B? Like, should I do group B like less than 70 without hypertension, without diabetes, without obesity? If it were the case, if you think that group B should be without risk factors, this will be considered wrong. Why? Because I have, a common statistical concept called confounding or confounders, okay, which may result in confounding bias. So for example, let's say that hypertension caused dementia, okay? And in group B, we include people without diabetes, without obesity. Okay, so now there is no matching, or there is no matching between two groups. So maybe diabetes can cause dementia, right? Maybe obesity can cause dementia. So if you get any result, this result could be subject to bias because you didn't control for other risk factors. So in order to eliminate this confounding bias, I'm going to match both groups. For example, group B, they should have hypertension, they should have diabetes, they should have obesity. Also, the age is very important here because, dementia has a risk increase with age. Okay, so it should be also more than 70 years. So everything is similar between the two groups except for the main disease of interest. So this group A is, associated with, like, they already have dementia. Group B should be without dementia. So everything is similar except for the main disease of interest. Okay, what about the risk factor? Should it be with risk factor like hypertension or not? Well, the answer is I don't care. I will get people without dementia and looking for their blood pressure. Like if you're gonna make like 2x2 table here, the disease here will be, on the top, which is dementia. And on the side, well, the risk factor here is blood pressure. So you see here, maybe we have high blood pressure, low blood pressure, plus, dementia or no dementia. So I don't care about the blood pressure in both groups. I will get both, like patient with high blood pressure and patient with normal blood pressure. Okay. So the typical answer here in the control group, it will be more than 70 years with hypertension, diabetes, obesity. They don't have dementia, regardless blood pressure is. So it could be high or normal blood pressure. Okay. So if you only choose high, it's wrong. If it's normal blood pressure, it's wrong. So I should have like, a mixture of these. Okay. Yeah, and also this concept is high yield confounding versus effect modification. Well, what if I said that coffee consumption increased lung cancer? So, in real life, it doesn't make sense, right? Like you already know that lung cancer, the risk factor for lung cancer is smoking. But, as you know, like statistically speaking, most smokers actually consume alcohol. So smoking here is considered a confounder, right? Um, because if you got to make a study, like enroll some people who are consuming coffee, most of them will develop lung cancer. But the fact is that smoking is the risk factor responsible for lung cancer. So this one is called, confounding bias. And what is the confounder here? The confounder is the one who already messed. Like maybe you can, match both groups or for some other risk factor like, BMI, age, sex, but you didn't match for smoking. So maybe group A, have higher percentage of smokers. Group B, there is low percentage of smokers. So when you try to make comparison between the two groups, it's not going to be fair comparison because, you should add smokers to both groups. So when you match both groups, it eliminates confounding bias. So as you see here, you can minimize confounding bias by matching. For example, when you're talking about case control studies, cohort studies, or basically, also can do randomization if we're talking about randomized clinical trials. So in the first slide, we have two types of, experimental studies, randomized versus non-randomized. So here, if it's non-randomized, it could introduce bias, right? So since I say it's randomized, the risk of confounding bias, is decreased. All right, what about effect modification? So effect modification, this one is not a bias, okay? So it's like a phenomenon that you observe uh, while giving treatment to a certain patient, for example. So let's say that drug X is more effective, in smokers than non-smokers in treating stroke. Okay, so here is the smoking. Smoking history is considered a modifier. Okay, so that's why the medication is more effective, right? Let me give you another example. Let's say that we have drug X that increase the risk of DVT in group A than group B. So we have two groups, female patients, but the drug X is more likely increasing DVT. So after further analysis, of these two groups, we found that group A, they have gene called, let's say, Y. So this gene Y increase the risk of DVT, especially when combined with a medication. So the gene Y is called, effect modifier because it produced some modification, right? But in the last example here, confounding bias, coffee consumption has nothing to do, right? The problem here is with the smoking. So there is no modification in confounding bias. All right. So in the exam, I'm going to ask you how to differentiate between, confounding bias vs effect modification, and the answer is do stratifications. So when you do stratification, in confounding bias, which is example A here, there is no significant finding. Okay, like you can see that both groups, the p-value is more than 0.05, which is considered non-significant. But when you do stratification and effect modification, well, you will see significant result in one group. So one group will be lower than 0.05. Okay, so once you do stratification, both groups are more than 0.05, there's confounding. If one of them is significant, i.e. lower than 0.05, it's called effect modification. Okay, I hope it make it clear. So you do stratification, and if it asks you how to minimize, confounding bias, the answer is matching or randomization. It depends on the kind of study. So don't get confused. You try to explore confounding by stratification, but you try to eliminate by matching or randomization. Okay, let's go to this example. As you see here, we have an epidemiological study investigating correlation between lifestyle factor, pulmonary health, and the researcher observed that coffee drinking exhibits significantly higher rate of lung cancer. So as you mentioned, coffee doesn't make sense, but let's see. After further analysis reveals that coffee drinkers in the study are more likely to be heavy smokers. So the smoker here is a confounder, right? That's called the confounding. Yeah, so you address by matching and randomization. The next question here is a new antiplatelet agent in preventing cerebrovascular accidents. So researchers perform a subgroup analysis based on lifestyle factor. They observe that the drug reduced the risk of a stroke, in smokers than non-smoker. Okay, so as you see here, smoking is a modifier. It affects, the effectiveness of the medication. So here we call effect modification. Okay. All right. So yeah, by this slide, I think we